hopefully the slides will be ready. Actually, David, do you want to introduce yourself?
Yeah, I'm David Hancock, and I am the chair and director of a community interest company called Interoperability.
Roland Agedy, Chief Data and Management Officer, University Hospitals Derby and Burton.
Oh, I'm a lead data scientist at the Health Economic Unit, which is part of the Midlands and Lancashire CSU.
Thank you very much. So how are we doing for the slides? Are we Okay, perfect. David Hancock, I think. Go first, yeah.
Okay, thanks. Well, fortunately, Tito's indulged me that I don't quite need to talk about the importance of terminologies and what I'm talking about is related to that, because of what I'm going to talk about is why it's difficult. And as you can see, I'm saying that interoperability is more a social problem than a technical problem. And what Pav talked about in the digital medicines, interoperable medicines, when she talked about the 6 problems that they have, 5 of them were social. They were not technical. So what I'll start off saying is looking at is, 3 particular examples of where interoperability failed. So the first one I want to talk about is what happened in London. So London has got a universal care plan, been very, very successful. And one of the priorities, one of the ones they wanted to do was a care plan around sickle cell anemia. Because of course, in London, there's a cohort there, a lot of people who have that problem because of the demographic. And so they wanted to be able to have that as part of the care plan and to be able to have that data interoperable. But they defined it across a couple of integrated care systems, and then they wanted to be able to expand that out further. And the problem, they were unable to standardize clinical practice that allowed them to be able to share that data. And that's because of the way in which clinicians in the ICS actually recorded data around a syringe pump. So they were therefore unable to share that information because the format and the way in which they used it was different. So they were not able to share that information. So you might see that as an interoperability failure, but it wasn't technical. It was social because we need to standardize that clinical practice. So another one, a good old discharge summary, the transfer of care. Now, this has been mandated in NHS England for, how long? 7 years, Lee?
It's probably getting on near a decade.
In fact, it was part of the NHS England contract for providers to be able to meet, for them to be able to work with NHS England. It was that level of a mandate. And yet, we still haven't been able to achieve that. So we need to understand why that's been impossible. I'm not saying what I've come up with is all the reasons, but I think these are ones to be able to consider. First of all, too difficult, because it was impossible to get the data together to go to the discharge summary. So even though we might have an EPR that's going to be able to produce this, it might not capture all the data. And that's again because of legacy, because there may already be systems that contain some of that data. If in order to be able to produce it, somebody's got to go and build the integration using an integration engine to go and collect that data together. You know what? Some of that data may be in a system which is so old, it's got very, very poor interface capabilities. In fact, you might not be able to pull that data out at all. So you've got, again, this legacy of different systems where you can't pull this information. Clinically not important enough for the acute. So if you read the PRSB discovery report about why transfers of care have been, a disappointment, one of the main reasons they come out with was in acute, they did not see it as being important enough to be able to produce that discharge summary. Now, there are many reasons for that, but quite often it's because you had the resident doctor who had to be able to produce it. And did they have the knowledge to produce it? Was it important enough for them? And then they would try and get something out. It might be late. They might not realize, did I actually send it out for that patient? And then they'll send it out again. The poor GP practice has then got 2 versions. And can they work out what's the difference? Is it going to be the same one or not? Nightmare for them. And then you got the inadequate knowledge to produce it, which again is down to the resident doctors. So That's the reason why it can't be produced. It's nothing to do with technical problem. It's a social problem. Finally, if we look at the area of advice and guidance, which is again has been is incredibly important, particularly as a focus that's been made by NHS England. Now, that has perhaps not been successful because of the collective action dilemma. This is a great sociological concept, which is, see what organisations realise it'd be far, far better off if they collaborated. But because of the priorities or what have you in these separate organisations, they can't. Look at the collective action dilemma around advice and guidance. So GPs and acutes know it's important, but in acutes, they're being measured on something else, i.e. how they're able to chew through this backlog. And they're also worried that if they do get an advice and guidance, what do they do with it? And they're worried they'll get into email ping pong, which again means that do they want to get into that? And so there's again, there's resistance to why they want to do it. They both know they should do it, but the way in which an acute clinician is being measured means they can't do it and don't want to do it. Again, that is a social problem. It's nothing to do with the technical problem. So I want to ask you, what have these things got in common? The Great Chicago Blaze of 1871, the Great Boston Fire of 1872, and the Great Baltimore Fire of 1905. And don't say they all happened in the US. So all three of them, when other fire crews from outside the city came in to provide assistance, they could not help because their hoses would not fit the hydrants. These used in those cities. And yes, America had more than 600 different sizes and variations of those hose couplings. And that is an interoperability problem. So after the Baltimore fire, the experience meant that they actually came up with the Baltimore standard for a fire hydrant size and hose couplings of 2.5 inches. So that was defined as this is what you need to be able to conform to. Inertia remained and conversion was slow. And even 100 years later, only 18 of the 48 most popular cities had actually made that standard. So hose incompatibility could be the Oakland firestorm, because Oakland's fire hydrants were 3 inches. So why did that happen? Because it's not a technical problem. Well, think about in the US, fire hydrants and hoses. There's an awful amount of legacy. They've already got all these things in place. What would it take to go and replace all that? A lot of money. Is it as important as other priorities they've got? No. So you've got all this legacy. You've got these social issues about the amount of clinical change, clinical standardization, clinical workflow that needs to be changed. There's an awful lot going on here to be able to make this interoperability actually work. Awful lot. So, will mandating standards in the Data Use and Access Bill work as intended? If it's going to work as intended, we've got to see all this change that we've got to make, this social change in order to make this technical thing actually work. And so when we're looking at this, it's not just about how we mandate these technical standards, it's the other things that have got to happen and how long we think it's going to take. And that's what something we need to be realistic about.
Thank you very much. We go to Roland next, and let me see if I can work this out. So we can shut this down. And that was sorry. You want to try?
Just gone to get some stuff.
Weird, the mouse isn't playing ball.
Is that a social issue or an interoperability?
A bit of-
A cultural issue, governance issue.
Antisocial.
It was in America. Concerned about going back home and.
Check how big them fires and hide.
Good morning. Roland Agidi, as per my introduction, Chief Data and Analytics Officer at the University Hospitals of Derby and Burton. 3 things to know about me: made in Nigeria, forged in Wales, resident in England. So, my opening gambit is interoperability alone will not save us if our applications are designed to track data. To my mind, strategic choices made in application architecture that prioritize functionality over data integrity and interoperability that led us to the current state of affairs across the path in the NHS. So enter a new term I coined for myself, application design debt. Not to be confused with technical debt, which is the compounding effect of the choices we make around how we code our applications. So to my mind, application design debt is effectively the prioritization of function and UI functionality over data and interoperability. So why is this important? For many, many years, the leading lights in our space have always posited the maxim interoperability at the data layer. So I'll invite us to examine our lived experiences. For the single patient record to become a reality, we have to solve 2 problems: technological and semantic interoperability. We all know that. If we think about the technological interoperability aspect, I think we have it licked. We've been able to do bulk exports for many years. We have APIs, we could do link servers, we have data warehouses, data lakes, data lake houses, you name it. Technology interoperability linked. We look at the semantic interoperability side of things. We have all these data standards: OpenEHR, FHIR, SNOMED, LOINC, ICD-10, you name it. So why haven't we yet cracked the single patient record problem? I say it's because of application design debt. What we end up trying to do, we'll be trying to link data from all of this myriad source system, is undertake what I call archaeological salvage work. If there are any data engineers in the room, we will know the pain it takes to link data from a lot of our legacy systems. So I say we scrap the old maxim of integration at the data layer and replace it with a new maxim: integration begins at the application layer within our systems of record. Okay, so how does this play out in reality? Skip too far. How does this play out in reality? Enter another term I coined for myself called the design debt cascade. It starts with UI-driven logic, applications that prioritize the function of the functionalities of the application over data, which leads to data fragmentation. So you get lots of applications where you have logic locked in the front end of the UI, which means the data in the back end is effectively unusable. That leads to integration decay, which means you can't link the data to other systems because you have lots of orphan records, you'll have a lack of referential integrity, etc. And what does that end up with? That ends up with unusable data. The consequences, as I've been touched by colleagues earlier on, clinicians unable to use data. We have huge costs setting up data engineering teams to link data, analytical failures, unreliable insights, and strategy failures, particularly at this time around the 10-year plan. So how do we solve this problem? I say we go to the data by design principle. Now, these are principles I think we might all be aware of in some shape or form around data first architecture, integration native design, metadata as a first class citizen, audit and lineage by default. What I am proposing at my local organization is that we have a procurement revolution, and I'm hoping we can scale that across the ICB and ICS, that we do not procure system or commission systems that do not have data extraction capabilities, that is not integration ready, that do not have metadata standards embedded within them, and do not have audit capabilities as a native function. So what does good look like? What does success in future look like? We have real-time care coordination, trustworthy insights or trustworthy AI, population health insights, and reduced clinician burden. So in closing, for me, system-wide integration starts within the application layer, and that's what we need to start to do today. I'll be happy to take any questions in the after session. Thank you.
Now, will this work? Yes, so is that your? So, oh, it's this one. Yeah.
Yes. Hi, as I said, my name is Melissa Coe. I'm a lead data scientist at the Health Economics Unit, which is hosted by Midlands and Lancashire CSU. So what we do is we provide economics, population health, and analytical consulting support for the health and care sector within the so I'm going to take on maybe a slightly different perspective of sort of the researcher and analyst perspective here, and thinking about really how interoperability has to enable the future of the NHS. So I've done quite a bit of work with national level policy analyses and evaluations. And I think one of the biggest thing that happens that we see is that we always constantly get asked to do, by clinicians or by policymakers, like, can you give us a national picture of how this health service is working for the NHS? Or, we're planning this new service and we want to understand like what other bits of the NHS patients have seen before they come to our service, and how does that compare to other services across the country? And that's actually such a difficult question to answer. And we almost always end up just kind of falling back on data from acute settings, from like hospital episode statistics or the secondary use of services, because there's more structured data there. It's easier to access. And I think we're really, really losing out on a lot of potential here. We're missing out on this sort of whole system, whole patient pathway understanding of what's going on with patient care. And why is this important? I think one of the biggest things that has been emphasized in the NHS's future and the sort of 10-year plan is this idea of more integrated care enabled by tech and AI. And that just inherently means we need more interoperable care. So if you have this vision of sort of multidisciplinary teams coming together and enabling the 3 shifts, so that's analog to digital, sickness to prevention, hospital to community, interoperability is going to be key to actually enabling all of these. And I think I'm going to frame sort of the next few examples around those 3 shifts. So hospital to community, this shift obviously emphasizes the need for moving hospital into communities. And one of the particular examples I think that comes in here a lot is virtual wards, also known as hospital at home. So these, if you're not familiar, are wards which are aiming to treat patients who are at a high acuity level, patients who would normally be in the hospital, but treating them at home instead. And one of the big emphases here is to have sort of tech-enabled care, so having remote monitoring, either by having patients with wearable devices that clinicians can monitor from remotely. So these models of care have really actually required new collaborations between acute and communities trusts, who are often jointly responsible for the virtual ward. So you might have like an acute consultant making some doing decision-making at a clinical level, with district nurses going in every day to visit patients. There's a lot of collaboration here. And as you can predict, this has come with a lot of challenges of coordinating between those specific acute and community record systems. And different data is absolutely being collected on the different sides of this. And adding on top of this, we've now also got new data that's being collected by all these wearables and remote monitoring devices for virtual wards. So we've seen that sort of data for things like procedures and tests that patients end up going into their acute care record, but home visits might get recorded on a community system in a different way. And one of the things that we see as a given, so like diagnoses for what patient diagnoses are given, isn't normally collected in community care settings because that's not as relevant in the same way. So what we've seen happen in this space really is that many new tech suppliers have come in and brought software that's supposed to adapt specifically to the virtual ward model. And I think one of the things we really need to think about here is how do we make sure that we're still future-proofing this to ensure we're not just adding on top of existing localized dependencies, another thing that's going to become a localized dependency in the future. And just before moving on, I think there's a lot being currently done in the space. There's a painstaking development I've heard of a minimum data set that's going to bring together a lot of data that was previously collected manually. But yeah, we're still quite a long ways to go in this integrated care space. The second shift is from sickness to prevention. So one of the things that the health economics unit does is a lot of population health management support. So this is using data to help councils and ICBs understand their local population's health needs. So that might be something like helping them to plan services based on doing some risk stratification to understand which patients might be most at risk of particular outcome, evaluating what the impactability of a particular targeted intervention might be. And obviously, to do this, we need access to really good linked data on that population. And there are definitely pockets of this across the health service. That's just the first bit. A good chunk of our health is determined by social determinants of health. So where you live and where you work and where you go to school. And if you have damp housing, are you affected by pollution, et cetera. And linking these types of data can often be really difficult. We have some aggregate indicators around deprivation, but just knowing that there's a link between deprivation and health isn't new. And how do we actually action on that? So one of the key points in this section of the 10-year plan is sort of getting people back into work. And one thing that we found in previous projects is that data on sick notes written by GPs, so for patients who are taking time off of work, something like 70% of sick note diagnoses just aren't being recorded at a national level because of different systems. Sometimes it's a free text field that you can't get anything out of it. We also don't necessarily know how long patients are receiving that sick or fit note for. Another example here is also unpaid carers. So people who are caring for people at home, they themselves can often be at higher risk of ill health and unemployment. And a study by the Health Foundation's Network Data Lab had found that 11 to 26% of carers only are actually being able to be identified between local authorities and GPs. And between those two, they don't really agree. So only like 7% of the carers that we found were actually in both sides of the record. So you might be with your GP. Your GP might know, but your local council might not. So yeah, accomplishing this shift of sickness to prevention really requires not just an understanding of data within the NHS and healthcare system, but also outside it. I think coordination across government departments, NHS, local councils, as well as potentially linkages to existing research data sets will be really key. The last one is from analog to digital. This is probably the most obviously related to interoperability, as I think the interoperability question is in itself part of the ambition here. But obviously you can't talk about analog to digital and not mention AI and the potential we think AI is going to bring to the NHS. I think in this case, really similar to sort of the virtual ward IT suppliers situation, it's really crucial for us to make sure that the existing systems that are there can kind of keep up with this addition of new tech and new data that's being collected as part of the flow. With AI in particular, I think we should be very concerned with the fact that the very data that we are talking right now is worrisome quality is the data that's going to go in to make the solution. So that tech solution is going to be as good quality as the data that puts into it, if not worse, because any existing biases tend to get amplified once you put it into some sort of machine learning tool or AI. And we know that this sort of poor quality data isn't random and it affects particular groups, mostly more disadvantaged groups more. So how do we be more forward thinking on what kind of data we really need and how this poor quality data isn't just going to affect care, but also how our AI enabled care of the future will look like. Yeah, and so finally, I just interoperability absolutely think will be key to practically achieving these three shifts in the NHS. Like we've heard already, so many other competing pressures in the NHS are set against us here. But I just wanted to end on a few questions that I absolutely don't have the answers to, but I think we need to reflect on in order to push interoperability forward. So first of all, who is this for? Are there potentially different solutions for patients and clinicians who obviously should come first, but is there a way of sort of making solutions for patients and clinicians that actually also then flows over to researchers in public health rather than creating things separately for different people? And how do we make sure the right people are in the room? I think that it's very much a social issue. And one of the things that we always find is there's a huge disconnect between the people who are generating and using the data and the IT and information governance teams. So like the number of times we go into a project and clinicians are really excited about us doing some sort of analysis. And then we ask, well, how do we get your data? And they say, we don't know. We don't know where it's stored. We don't know who to talk to. We'll find out for you. And they often do, but some sort of broader awareness of data and information governance across the NHS in all, for both clinicians and patients will be really important, as well as outside in order to collaborate with those other organizations. Obviously, I think on the ongoing reorganizations at national and local levels is making this really difficult. And I think it's part of it is also a bit of a lack of continuity of the people that are in charge of data. But yeah. We also collect a lot of data. And I think not just thinking about what data do we need, but also do we have means to use it well. So that might just be like on a system level, do we have the right systems, but do we also have the right people? And like, what is the data engineering and analytics capability and data management capability, the areas that we want to use data? And are those people connected with the frontline staff and the patients so that they can actually have some sort of conversation about what the data is, how it's being. And then finally, given all of this, what are the highest priority areas that we need to work on, either because they're the easiest to get done or because they're the most fixing? Definitely don't have the answer to these questions, but I think that the reality is that there's many, many complicated discussions that need to be had with lots of different stakeholders in the room in order to really achieve these goals. But I hope that this has helped to illustrate a little bit about how this sort of vision for the NHS's future is really inherently linked with interoperability question. Thanks.
But now, I think that was a great sort of varied perspective on the side. On the field and the challenge. It's interesting to consider what Ming Tang acknowledged earlier, which is that the degree to which the NHS needs to improve it, both its data management and its enterprise architecture, is significant, and there's a big challenge there. And I think this kind of helps to frame some of that in the context. So do we have some questions? Well, I'll ask.
I'll throw one.
Sorry.
Similar question really around marketplace. We talk about interoperability and how we're going to get there. And for me, it's the same market question. You make it a market entry requirement. Would that work? How would that work?
Yeah, so I've worked in vendors. I've even worked at Oracle before it went a bit mad with Larry Ellison quite being where he is now. But Oracle, for example, had a huge product development organization. Yeah, it was still finite. And they would develop things that their customers wanted. I can genuinely tell you that more often than not, interoperability was not at the top of the customer's wish list. And so product companies will develop what their customers actually want, because they've got finite resources. So you actually find that is a reason. Now, I agree about the problems with the market in primary care. That is definitely skewing things. But sort of looking at that as a first thing, then I was talking about the interoperability. Is it actually possible? Because we have all these social problems. Is the data the same? As I said with syringe pumps, if they need to be standardized clinical practice, standardized clinical workflow. This is really, really hard stuff. I'm not saying there are vendors who create blocks on not doing it, but I can tell you all the vendors I've worked for absolutely want to do it because they want to make their customers happy. But they will do things that make their customers happy. And more often than not, it's not interoperability that their customers want.
I think the market question is mainly around procurement standards and data by design principles, as I pointed out in the presentation. Now, I know there are countries in Europe, I can't remember if it's Sweden and Switzerland at the moment, who actually mandates the standards for procuring health systems. I think that's the direction we need to go. So being able to get that marketplace in the right place to facilitate interoperability.
Yeah, I think I've probably just.
Yeah, there's one other thing. So one other thing I would say is that when you look at procurement in the past, they quite often say, can you support fire? It's absolutely meaningless. Totally meaningless. What you should be saying is, can you support this API? The problem is right now we don't have standard APIs in the world of fire apart from GP. So again, it's down to, what are we actually specifying? And it's a problem going back to, do we have policy? Do we have the infrastructure? And then do we have the APIs? And we don't have that. So again, we are shooting ourselves in the foot because we're not creating that environment.
Sorry, Melissa.
Yeah, no, I think I was gonna say, it's probably very similar to what you were going to say anyway, but I think, is there kind of question of who's doing the procuring and like what are their priorities? I think there was a study that I put in the slides that was looking at virtual award suppliers. And one of the quotes is something like, you know, there's so many different suppliers, it's just like, it's like kind of hard for us to even like, you know, get a grasp of what's doing anything. And then ultimately, we just decided based on price.
Yeah.
So like, so yeah, I think how do you get interoperability if that's the main concern? It's just who will deliver something to us for cheap. I'm not saying that's everybody, obviously, but that was one quote.
Thanks. Behind me, sorry.
It's more of an observation and also a reflection on previous presentations as well. So I'm offering an observation and also your thoughts and opinions, but a lot of work is going on to try and create that integration either through a system lens or a geographical and an organizational lens. And you know, one of the things we've all been through the previous national programs and challenges where we've tried to bring interoperability together. Wouldn't it be great if that integration, that complete picture came together at the patient level, not through an organizational lens or a system lens, and actually create the national infrastructure to join that data up at the patient level, which then organizations or systems can then integrate and interoperate with. You know, some work going on in Scotland, but I think my challenge is we all look at this problem from our own different perspectives. We just almost need to take the ownership of the data or own it or those kind of challenges to the level of the patient and actually try and tackle the problem from that perspective.
I can address that. So I know the work going on within the NHS Federated Data Platform to build a canonical data model, moving us in that direction and beginning to set the framework around which we can have that national interoperability model, if you might describe it as such, but it's still very early days. So
Yeah, I would say that we do already have quite a lot of that. Look at the shared care record. The thing is that the shared care records are typically trying to manage a geography which includes all the patient flows. So we're doing quite well in that way. I accept joining up shared care records is something else. Another observation I would make, and I really understand where you're coming from when you're talking about social care and third sector, in the work that I've been doing, I've done for the last 15, 20 years, is one of the major obstacles for social care is that has been no real information model. We need an information model to then be able to define what the basic building blocks are, what's the basic data that we've got. And because we don't have that, it makes it very difficult to be able to integrate it all together. Having said that, shared care records are still doing that. It may be unstructured data, it might be limited in the structured data, but that is giving us something, and I think that's something we should build on.
The other barrier to third sector is access to funding and investment as well. A lot of the focus has been on primary, secondary care systems. I think if we're going to move to community-based preventative services, the investment needs to follow that integration as well.
I think Lee and Philip.
Yeah. So, my question is, we've got the new Data Access Use Act coming. We'll make it a legal requirement for interoperability and implementation of standards. Is that going to help or not the conversations we're having today?
I think it will. Again, we've talked about having the statutory basis for being able to take forward some of these agendas. You know, there's been a gap in that space. And I think this begins to move the needle forward in terms of being able to get more money to do these things.
Yeah, Lee, if we look back on things, we've had it to be trust to be mandated to be able to support standards, and if they feel they can't, they've been able to say, as long as they can give the reasons. And again, it's down to, can they generate, come back.
Yeah, so just on that one, under the 2020 Change Act, enforcement now can go to trusts from that act for not implementing ISN. So enforcement actually becomes a realistic option where previously it wasn't. Now suppliers have yet to got the regulation aspect
Correct.
sorted, because that's not quite there yet. But I guess the question is it a positive or a negative? Albeit there's a regulation wrapper that's necessary.
Totally positive.
Yeah.
Totally positive. It's how we get there. But I think that would be fantastic for us to do. As a patient, I absolutely want that. It's how we get there. And I think we've got to be realistic on how we do it.
I think we've got a question coming in from an online. Is that right, Jan?
Loads of questions.
You've got loads of questions.
You need to be near at the front, Jan, so you can get in there first.
So, I mean, there's one which is around the independent sector and how can we get them engaged so that they're also part of the single patient record and supplying data for analysis. And there's another one around legacy systems. You know, obviously they're going to remain. How do we get them to and from? I mean, very different questions.
Does anyone want to take that? So could you repeat, you were a bit quiet.
Oh, sorry. Okay, so the first one is about independent sector and how to get independent sector part of the discussion around interoperability. And the second one was about what can we do with the legacy systems? They're not going away. How can we get them to interoperate?
Does anyone want to take that?
I'll take the second one. One of the issues, again, with the mandating of the standards is, as I said, you're still going to have a lot of data potentially in legacy systems. Problem is the responsibility for then using that to be able to create the standard, maybe it's like a correct transfer of care or what have you, is going to be down to the trust, the organization. And they're going to need to have the skills to be able to use their integration engine to be able to get that out and to be able to produce the transfer of care. And it's their it'll be their responsibility. That is quite something for them to be able to do. And where are their priorities? You know, so we have to understand that there is a set of issues, but absolutely you should be able to do it using your integration engine, but it can be technically difficult and it could be difficult from a prioritization perspective.
I'm happy to address the question about the independent sector. So I think that's a very good spot there. There's been a gap in engagement with the independent sector historically. We've done a lot of work between primary care, secondary care, health and social, etc., but we haven't really integrated with the independent sector. Now, I think the frameworks already exist around the MOUs, the data processing agreements, all the relevant instruments that allow us to share data between primary, secondary, and social care that can be extended to the independent sector. And I also think that we are now standing up the architecture that allows that to become a reality. So the secure data environments, places like the SAIL data bank, HDS, etc. All of those give us the capability to do that. So I think just marrying up those two capabilities and inviting the independent sector to the table gives us the paths to being able to get them involved in this work.
I mean, I don't have that much with the independent sector, but in terms of the legacy systems, really similarly, I think it's a lot about like having the right people in the room at the right time. And like, as you say, there have been a lot of pushes. I know like Guy's and St. Thomas is moving over to Epic or whatever, but I think part of the issue is like, you know, making sure that we're not just creating new legacy systems that are like in, 20 years down the line, we're going to again be like, oh, well, we've got all these legacy systems and how do we join them up better with a new one that's going to inevitably appear. So I think, yeah, it's just that forward thinking, I think is quite hard, and having the right people who can do that or know that. I don't know.
So I can address the legacy system because again, that's something we're dealing with on a day-to-day basis. I think the canonical data model, lots of work we're doing within the shared care records, etc., to map data to data models that can be shared across regions will help. Legacy systems are not going away anytime soon. I think what we need to do is make sure we have those artifacts. And I think the FDP gives us that interoperability capability where you can take data from legacy systems and map it into model the data standards. We just need to keep or maintain that capability within the FDP. And that allows us to consume information or data from legacy systems that are not adhering to any particular standards into more modern systems that adhere to acknowledged standards.
Yes, sir.
Sorry, it's not that it's a comment you made earlier, saying that we need to talk about integration with specific APIs rather than just a vague, are we fire compliant thing? I was just a bit confused, like, what are you said there were no standard APIs, we don't have them. I would have thought that all the central NHS Digital, NHS England fire APIs, there's dozens. of them.
Yeah, so there are APIs for central systems,
Like
like
PBS fire.
PBS or what have you. What I'm talking about is APIs for example, EPRs to talk to EPRs. Or even, EPRs talk to shared care records or what have you.
So
That's the-
directly
that's the
rather than
API.
go
So the things, particularly the things at the point of care. So that's what I'm talking about to understand.
I just want to try and fit one more question. I think Philip, you had the question.
Thanks. I just wanted to pick up on the design debt that Roland was talking about. There seems to be a recurring theme that existing technology, and I would argue all NHS technology is legacy as it stands today, was built around how the NHS used to work. And GPIT is the way it is because that's how the GP contract works. Need to support that further. And EPRs are just EPRs that were designed to support the way American hospitals work.
Yes.
So does there not need to be a bigger, deeper discussion about what it is we actually want these systems to do to support both patients and a redesigned health service? And without that, the data is always going to mean different things in different places and lack context. So is that conversation happening or is it going to be happening?
I think it may happen later over coffee because stop. But it just remains to
Well,
have the panelists
thank you very
a
much.
copy of someone's book. Thank you very much.
Thank you.